Hello, my name is Francesca Derderian, and today I am presenting my DMP scholarly project on palliative care consultation in an intensive care setting. Dr. Gail Pitroff is my chair for this project. To introduce this topic, I want to talk about how underutilized palliative care is in the inpatient setting, especially in the ICU. There are many chronically ill patients with multiple comorbidities in the ICU with reduced palliative consults. ICU providers tend to focus on the problem at hand rather than any subsequent or underlying condition management, but palliative care focuses more on symptom management and patient quality of life. This project integrated a palliative care screening tool to be utilized in the ICU setting to increase palliative care consultations. In discussing the phenomenon of interest, I wanted to talk about statistics a bit. ICU admissions for patients in the last month of life have increased in upwards of 30%. Hospital admissions are an important indicator for death, as 12 to 35% of patients will die within 12 months of admission, and 90% of older adults have a chronic condition, while about 77% have two or more. 75% of deaths among older adults resulted from a chronic condition. For those with non-malignant causes, there was a limited or late access to palliative care. This marks the importance of integrating palliative care into patient treatment early in the course of the disease. Consultation has been shown to significantly decrease hospital costs, increase survival, decrease hospital length of stay, improve quality of life, and enhance patient and family satisfaction with care. However, palliative care is not universally accepted, so there is decreased utilization. Approximately 22% of nurses still believe that palliative care is only for the actively dying. This shows that there is a great lack of knowledge surrounding this topic. There is a disconnect between an appropriate screening tool and an actual palliative care consultation in an ICU setting, which is why this topic was further explored through this project. I have a personal connection with this phenomenon because I currently work as a nurse in the medical ICU, where we see many chronically ill patients that have increased mortality rates due to various reasons. All ICU nurses at my facility are required to attend a course called Impact ICU, which discusses integrating palliative care into the ICU setting. After attending this course, I noticed a really big disconnect between a need for consultation for our patients and actually getting consults. This sparked my attention, and I noticed a great need for change to improve care in our facility and the quality of life and satisfaction among our patients. The purpose of this project was to implement the Center to Advance Palliative Care, or CAPC ICU, palliative care screening tool to increase palliative care consultation in the ICU. As a result, the project aimed to improve quality medical care and quality of life among chronically ill patients and their families alike. The type of inquiry for the project was a practice improvement project. It utilized an established evidence-based palliative care screening tool, the CAPC ICU tool, upon admission by nurses. This tool produced a score that was utilized in recommending a palliative care consultation. The data collection surrounded the score derived from the tool and a chart review to determine if a consultation was made by the provider or nurse following an appropriate score. Evidence-based literature shows that palliative care screening and assessment tools have been helpful in improving palliative consultation and patient outcomes in the ICU environment. Consultation usually only occurs at the end of life, if at all, in the hospital. It is important to introduce palliative care earlier in the progression of disease. Multiple studies have utilized palliative care screening tools to increase consultation rates. A study by Surratt et al. Found that after a year of palliative care screening tool use, the consultation rate increased by 113% in the medical ICU and 51% in the surgical ICU. Also, a study by Robbenheimer et al. Found that participants that were identified as needing palliative care from the tool had significantly lower mortality rates over a year after admission. Furthermore, two studies in particular studied the CAPC ICU tool. The first, by Anderson et al., found that the inter-rater reliability between provider responses was significant and substantial. Another study by Lapp and Iverson found that the tool significantly predicted the probability of being referred to palliative care, and that the number of criteria met on the CAPC screening tool showed significant correlation to the probability of dying in the ICU. This project was significant to nursing and the patterns of knowing. ICU nurses are typically treated in a cure fashion rather than focusing on symptom management and chronic illness. Palliative care focuses on treatment alignment with patient preferences, support, and continuity across multiple care settings. With the use of these services through Consult, it ensured equal and correct treatment among patients. In addition, approximately 25% of patients in the ICU will die during their admission or right after discharge. Many patients are struggling with one to multiple comorbidities. Most ill patients will be placed on mechanical ventilation, have invasive lines, pharmacologic medications and drips, central monitoring systems, and other forms of organ support based on disease presentation. All of this costs a substantial amount of money. Approximately $82 billion in the United States annually is spent in the ICU alone, and about 25% of these patients will die in the ICU. Palliative care is a way to bridge this gap between the costs, length of stay, and patient satisfaction. Furthermore, palliative care consultation is imperative to advanced practice nursing. Though they have many roles, advanced practice nurses are also committed to quality and safety through practice to continuously improve nursing care. The support of advanced practice nurses will help to increase consultation consideration not only in the ICU setting, but it could assist in developing success in care beyond discharge. I performed my project at Walter Reed National Military Medical Center in the medical ICU. The critical care and palliative care directors were both on board with this project. There was also a facility student advisor that was informed, and I had a project mentor at the facility as well, who was a CNS and DMP that assisted with palliative care too. Through the implementation of this project, the facility sustained many benefits to the practice setting. Through the integration of the CAPC ICU tool, patient outcomes increased. These patients should have also had a decreased length of stay in the ICU, and it should have decreased costs to the facility at large. Finally, these consultations increased benefits through better symptom management, continuity of care, communication, and treatment through patient preferences. This improved patient and family satisfaction with care. The population intervention control outcome, time, and setting question for this quality improvement project is, in adult patients, does the implementation of the CAPC ICU screening tool identify patients and initiate palliative care consultations upon admission to the ICU setting? The Maryville University Library with multiple databases was utilized to perform this advanced search. There were 4 themes derived from the literature. The first was palliative care use in the ICU and associated barriers and challenges. Multiple studies have shown benefits to palliative care screening. Studies showed that palliative care screening significantly increased consultation rates, new do not resuscitate orders, and hospice referrals, lower 30-day readmission rates, reductions in the average length of stay, and direct cost reductions. The barriers and challenges included selection bias with palliative care screening tool use, and Wang et al. Found that 7.9% of patients needed help making complex decisions, determining goals of care, and understanding palliative care in general. Also, most research studies focus on screening tools being used on admission. This can be an issue due to escalation of care or worsening critical illness after initial admission. The second theme is surrounding palliative care screening tools. The tool developed exclusively for ICU use is called the CAPC ICU tool and is indicated for patients that have a high likelihood of having unmet palliative care needs in this setting. For example, Lapp and Iverson found that the number of screening criteria met was significant in predicting the probability of being referred to palliative care and of dying in the ICU. There are no current studies on the reliability or validity of palliative care screening tools for use in the ICU at this time. The third theme focuses on education of nurses and providers. There is a major lack of knowledge surrounding the purpose and uses of palliative care. A lot of literature discusses a method of education or training for the staff involved. The final theme relates to patient outcomes. The first major outcome was a positive consultation rate after palliative care screening tool use. Studies found that a significant difference in both ICU and hospital length of stay after implementation of a palliative care screening tool. Positively identifying patients significantly affected survival rates within 12 months of screening, and it showed significantly higher rates of new DNR code status change for those receiving consultations after screening. There are a few important strengths to mention. The first involves the tools utilized in performing palliative care screening. Palliative care screening tools can positively identify patients in need of consultations. Also, studies were performed at multiple settings, and there are multiple studies that were performed prospectively. There are a few weaknesses worth noting as well. Most studies in the ICU are retrospective. Additionally, to date, there is no valid, reliable, or standardized tool to assess for palliative care needs in an ICU patient. Furthermore, many of the studies contain small sample sizes and were only performed in one setting. None of the studies performed a power analysis, and in addition, most studies screened participants based on convenience. There were no randomized controlled trials in the literature. There are also a few limitations. The palliative care screening tools could provide issues with selection bias. In prospective data collection, the tool may have positively identified patients, but it was the provider's decision to follow through with this assessment. Also, studies were configured to screen all patients upon admission. However, many studies missed patients in screening. There are two gaps identified in the literature. The first is the lack of a valid screening tool, which is standardized across the literature. The second is a lack of provider education surrounding palliative care. Many of the studies focus on educating nurses but fail to include providers. The conceptual framework that cohesively reflects this project is comfort theory by Catherine Kolkaba. This theory is specific to nursing practice and is described as a framework for art created through nursing-directed activities. The theory is broken down into relief, ease, and transcendence. Kolkaba also researched holism in relation to comfort. The theory assumes that comfort is a basic need that must be achieved holistically. Kolkaba's comfort theory can be utilized in this setting to promote healing in the palliative care initiative for this project. A quantitative exploratory design through a retrospective chart review was utilized for this project. The data was extracted from the EMRs for adult patients who were admitted to the ICU. All patients were screened on each nursing shift using the CAPC ICU screening tool to assess for palliative care needs. Those who were admitted to the MICU from May 1, 2020 to October 31, 2020 for the pre-intervention timeframe, and from November 1, 2020 to April 30, 2021 for the post-intervention timeframe, were screened for palliative care consultations. The screening tools were only utilized as a nurse-driven tool to indicate a need for palliative care and were not extracted for data use. Data was based on the rates of those consulted to the inpatient palliative care service through the EMR. A data collection sheet was utilized by the author to track those who were consulted to palliative care, ensuring that no patient identifiers were included. This project was performed at a hospital in the eastern region of the United States in a MICU. The sample included adult patients 18 years and older who were admitted to the MICU. All genders and races were included in the data collection. Inclusion criteria for the EMR to be included in data collection was as follows. The EMR had documentation that the participant was 18 years and older. 2, the EMR had documentation that the participant was admitted to the MICU between May 1, 2020 to October 31, 2020 for the pre-intervention timeframe, or from November 1, 2020 to April 30, 2021 for the post-intervention timeframe. Exclusion criteria for the EMR to be excluded in data collection for this project was 1, if the EMR had documentation that the participant was less than 18 years, the EMR was closed and no data was retrieved. If the EMR had documentation that the participant was admitted to the MICU before the pre-intervention timeframe or after the post-intervention timeframe, the EMR was closed and no data was retrieved. And 3, if the EMR had documentation that the participant already had a palliative care consultation, the EMR was closed and no data was retrieved. A sequential inclusion and exclusion process continued until at least 200 EMRs were achieved. Participants were not engaged and no patient information was abstracted from the EMRs. EMRs from the chosen facility were utilized for data collection. The author recorded a minimum necessary data to accomplish the goals for the project on the data collection sheet. All potential patient identifiers were removed and were not collected for this project. And here is a copy of the screening tool. This was a nurse-driven tool and no data was collected from the use of the tool itself. Data was extracted from the EMR based on if the patient received a palliative care consultation. And here is the data collection tool for the project. There are no current studies on the reliability or validity of the aforementioned palliative care screening tools for use in the ICU at this time. There have been many tools that have shown positive and significant results, but none have been tested for their psychometric properties. Most studies have used tools based on set guidelines set forth by the CAPC and the IPAL ICU project, but they are not replicated in multiple studies. There were no foreseeable physical, psychological, social, economic, or legal risks that resulted to patients under the direction of this project. One possible risk that could have occurred is a breach of confidentiality. However, this risk was minimal. Through this scholarly project, the researcher intended to actively protect each patient involved. The researcher recorded the minimum necessary data to accomplish the goals for the project on a data collection sheet. Through the retrospective design of this project and the specific safety measures in place, protection of human subjects was accomplished. This scholarly project was retrospective in nature and involved comparing palliative care consultation rates pre- and post-intervention. The statistical program statistical package for the social sciences, or SPSS, was utilized to analyze the retrospective EMR data. The data utilized was interval in nature. After researching and discussing with the Maryville University statistician, it was decided to utilize a z-test for the difference of two proportions to examine the data in this project. Descriptive statistics were used to assess the demographic data of both the pre-palliative care screening and the post-screening groups. The sample consisted of 39% female and 61% male patients, and here is a figure of the gender breakdown pre- and post-screening tool implementation. The setting of this study took place in a MICU in an urban medical center located in a large metropolitan area in the eastern region of the United States. The hospital inpatient team cares for approximately 500 admissions per month, and the MICU on average cares for approximately 1,500 patients per year. This facility is a level 2 trauma center, a stroke center, and a cardiac center. This was a quantitative exploratory design that compared palliative care consultation routes pre- and as compared to post-screening tool implementation. The sample consisted of 855 adult patients who were seen in the MICU between May 1, 2020 through April 30, 2021. The patients were split into two groups based on the implementation of the CAPC ICU screening tool, which was implemented on November 1, 2020. There were no palliative care screening tools that were utilized before this time. Here is the project implementation timeline, which starts with a planning phase in 2019. The palliative care screening tool was selected and IRB approval was obtained in December 2020. Education was provided to nurses in October of 2020. The implementation of the CAPC ICU screening tool occurred on November 1, 2020. The results and retrospective EMR data was analyzed from May to June 2021. For this study, an upper tail z-test for the difference of two proportions was utilized to determine the significance of differences between palliative care consultation rates pre- and post-implementation of the palliative care screening tool. Although palliative care consultation rates increased after the implementation of the screening tool, the z-test indicated that this difference was not statistically different between the two groups. It can be concluded that there is insufficient evidence to suggest an increase in consultation rates from pre to post screening tool use. And here is a table showing the number of consultations pre and post screening tool implementation. And here's another figure that shows the consultation rates increasing after the implementation of the screening tool. There are many factors that may have affected the significance of the results in this project. The first could be related to timing of the project. The short time frame of 6 months may not have been a sufficient amount of time for all staff members, including providers, to gain proficiency in using and understanding the new screening tool. Another significant factor lending to limitations in this project relates to the timing of the COVID-19 pandemic. The pre-intervention period for this project was in the midst of the beginning phases of the pandemic. The COVID-19 illness affected many different factors in this setting, such as admission rates, increased critically ill patients, and death rates. Once providers noted that they were exhausting all of their critical care resources, they may have turned to palliative care at an increased rate to provide imminent death support. Likewise, the hospital's EMR system was unable to embed the palliative care screening tool into the information technology system. The tool was subsequently printed on the nurse's daily report sheet and rounding tool, so it was a nurse-driven screening. Failure of the nurse to fully understand or screen the patient based on the patient's history and acute illness may have led to a lower score on the screening tool. This may have prompted decreased positive screening and scoring for the patients and subsequently decreased palliative care consultation rates. Furthermore, consultation rates were dependent on physician approval, as they were ordering the consultations in the EMR. There was a major disconnect in provider understanding and education. While multiple efforts were made to educate providers of palliative care on many occasions, there were still many providers that were resistant to this need. Additionally, the project took place in a single unit in a single medical center, and generalizability was lacking. There were many associated barriers and facilitators that influenced this project. Barriers to the project included a lack of motivation to change, lack of provider involvement, lack of standardization due to utilizing a paper tool rather than the EMR for data collection, and time constraints. On the other hand, facilitators to research are those that positively lend to the study outcomes. Education and medical center cooperation were both facilitators to this project. There are many reasons for differences between observed and expected outcomes in the project. The expected outcomes of the study were to significantly increase palliative care consultations after implementing the CAPC ICU screening tool to identify palliative care needs. While this study did not produce statistically significant results, there was a positive increase in consultations post-implementation, lending to the clinical significance of the study. If various barriers are addressed in future studies, the results will most likely show an observed change towards significantly increasing palliative care. This project had many implications. First, it shows that there is still a lack of education surrounding palliative medicine, and there's a major disconnect between provider understanding and consultation. Additionally, the study highlights that barriers that exist within palliative medicine in general. Early identification of patients who have a high likelihood of unmet palliative care needs is essential to providing timely and effective interventions, leading to higher quality of care. This study identifies that education was successful to increase knowledge and social ramifications, but that there is still a great need for palliative care screening and use. The results of nursing research have become increasingly important to practice and influence on healthcare policy. Studies must identify the scope of the problem, aim at offering practice improvement methods to render different outcomes, and illuminate a need for change. The project showed the importance of developing healthcare policy on palliative care education and use in critical care. Providing high quality and safe care among patients in nursing is of utmost priority, especially in the critical care setting. This helps to increase patient outcomes and allows for evolving and updated evidence for practice. This project focuses on increasing consultations, which will reduce hospital costs, increase survival, decrease hospital length of stay, improve quality of life, and enhance patient and family satisfaction with care. Through the implementation of the CAPC ICU palliative care screening tool, this practice improvement project increased overall palliative care consultation rates in the critical care setting. While the results of this analysis were statistically insignificant after implementing this tool, there was still a positive increase in consultation rates when compared to having no screening tool. The project identified and highlighted many barriers to palliative care in the setting in general. This assists in further progression towards future studies and implications for action regarding palliative care medicine in the ICU setting. And here is a list of my references. Thank you so much for watching my presentation. Please reach out if you have any questions.